In this video, we're going to talk about examination of the patient with dementia. Examining the patient with dementia is sometimes quite challenging, and it also encompasses a mental and a physical examination. First, we're going to cover a mental examination and the importance of that, and one that you can use in clinical practice. And then we're going to move on to physical examination and some tidbits that I've learned in clinical practice that might be able to help you. First of all, we're going to talk about dementia screening. Obviously, screening is dependent on the problem being recognised, and that's where you as paramedics come in as really important practitioners to be able to recognise those patients who might have dementia but aren't yet picked up. Remember, the signs and symptoms of dementia are memory loss, and generally this is short-term memory that we're looking for. Your patients will typically be disorientated to time, and they'll start to have difficulty with the daily tasks, washing, dressing, shopping. And it's really important to start to recognise those signs and symptoms when you enter patients' home, and they might be able to cover them quite well. You'll also find that they'll be confused and disorientated. They may have difficulty speaking or communicating with you. As we talked about in the cortical and subcortical video, this could also be problems with speech production, but also with comprehension. So they might just seem confused at what you're saying and not be able to understand you at all. They might repeat themselves quite a lot. That's to do with their short-term memory because they've essentially forgotten what they've already said to you. They might have decreased social interaction and appear quite withdrawn, and they might also start to have hallucinations and paranoia as well. So recognising these signs and symptoms is really important because this kick-starts the dementia screening and is able to help these patients and support them. The earlier we pick up these things, the better. And that's because we can start some medication off, such as Memantine or other medication in Alzheimer's disease, to try and slow the progression and also try and relieve some of the symptoms that patients experience. Also, more importantly, we can start off personalised care, and we can actually start to get people care and help if they need it, and start to plan for the future for these patients, which, as you appreciate, is very important. Once highlighted, patients can attend a memory clinic, and those are typically held at Hull Royal and requires a referral. And what happens here is that patients will have some of the tests that we're going to go on and talk about, but also the planning for the future can start as well, and it puts these patients within the care system so that we can monitor the progression of the disease and put in more care if needed. And also we can teach patients some tactics to be able to remember things, and they get that psychological and social support that they need at this stage as well. Plus, it's a time that we can start to support their family as well. So this is something called a comprehensive geriatric assessment that happens at the memory clinics, and these are really important. All of these things rely on you being able to pick up these patients who may need it and flagging it up to secondary care if you take them in or referring them on the appropriate pathway. In terms of assessing these patients, the gold standard to use is the mini mental state examination. It's a really long test. It takes about 25 minutes to do. Obviously, this isn't something that's appropriate to do in the patient's own home. What you can do is something called the Abbreviated Mental Test Score, and this is really fast and effective and should take you no longer than a couple of minutes to complete with the patient. And we'll go on to talk about that in a couple of minutes' time. What the AMTS starts to do is give a baseline of the patient and alerts you to if they need referral to the memory clinic and a mini mental state done as well. And the important thing about this is that it can be repeated as well in secondary care, because what might happen is your patient might have a delirium and then it's not appropriate to do the AMTS. In terms of the mini mental state examination, and this is something that it'll look like, and as you can see, it gives the patient a score out of 30, and what we're looking for is that they have a score no less than 27. If they had 27 or less, we would start to suspect that they may have early cognitive impairment or some type of dementia. And what you can see from the questions is a lot of them are based on calculation. So we're asking the patient, what is the year and where are we now? We're trying to discover if they're orientated to the time and place. The third one tests memory. So what we're asking the patient to do is name 3 objects in the room and remember them. And then here as well, we're asking them to count backwards from 100. And what you'll see as you look at these is that a lot of them are trying to discover if the patient can calculate, if they're orientated to time and place. And those are the typical symptoms that you'll find with dementia as well. And the less orientated to time and place they are, the less the score, and therefore the more likelihood that they have a form of dementia. But unfortunately, this doesn't tell you which type it is. We need to do other clinical tests later on to discover that. The test that you can do quite easily in the patient's own home is called the Abbreviated Mental Test Score. And if we just take a look at it here, it's just this section here. And it's a really quick test to do that gives the patient a score out of 10. And what you want to do first is that they get 1 score for a correct answer and 0 for a wrong answer. There are no half points, and a lot of people will give the patient 8.5. You've got to be really strict. It's either correct or not correct. So out of the questions, what we're first trying to do is discover their orientation and their memory. So we're going to ask them their age and their date of birth, and they'll get 1 for correct, 0 for none. The next one, what we do is we ask them to repeat a street, and this is normally 42 West Street, and make sure that your patient can repeat it back to you. We then ask them what the year is and the time, checking their orientation to time. We ask them where they are at the moment, so where are they, in the hospital, in their own home. And then we ask them to name 2 people around, so this could be you as a paramedic and your crewmate, or this could be you and a carer who's there as well. And then we ask them the year of something that happened, and this is typically when World War II ended, because our patient groups around that era as well, or this may have to change a little bit as well, because some people even in their 50s might not know when it ended. We then ask them who's the current monarch, so that's Queen Elizabeth, although that may change and we'll have to change that. And then we ask them to count backwards from 20, testing their calculation, and they have to go right back from 20 to 1 or 0 to get that point. And then finally, testing that short-term memory, we ask them to repeat that address beforehand, which was 42 West Street. So you could even try this on yourself, and it's really difficult sometimes if you have a patient who's ill and it's in the middle of the night. They might not perform too well. So this is a really good test that can be done in the patient's own home. They get a score of less than 8, which should highlight that this patient may possibly have dementia, and it can then be repeated in secondary care or at a later date to find out if the scores are the same or different. Physical examination of the patient with dementia can sometimes be really challenging, especially if they're quite hyperactive and aggressive. But remember, try and keep a structured approach. Examination techniques remain the same. Inspect, palpate, percuss, and auscultate. And if you're doing an orthopedic examination, look, feel, move. Try and keep things the same, and then you're less likely to miss out a step. The key with it, I would say, is communication, and often that's reassurance and repetitiveness with the patient as well. You've got to constantly reassure them of what you're doing, why you're doing it, and who you are. Because don't forget, they might have forgot that by the time you get from inspecting to palpating as well. Explain what you're doing fully and why. And if the patient doesn't want you to do it, the best thing is to move on if you can and if it's safe. And take your time as well, slow down. What you'll see from the communication video is that because they have that trouble with comprehension, sometimes you've got to repeat things quite a few times before they're able to comprehend it as well. So try and slow your speech down as much as you can, and you can even use your non-verbal body language as well to try and demonstrate what you're going to do. And you're trying to maintain that trust with the patient, which is really important if you want to complete your examination with them. Explain fully what you're going to do and make sure you get consent. And then also maintain the patient's dignity as much as possible. You find that the elderly don't particularly like their cardigans being removed, and they want to maintain the dignity, especially if there's others around as well. Try and adapt your examination to meet the needs of the patient. Sometimes what you can do is you don't have to completely bare the patient's chest to auscultate. It would be acceptable to try and slip your stethoscope under the patient's top to listen, and maintaining this patient's dignity is going to contribute to less stress to the patient, which is going to contribute to more cooperation, hopefully. You can use distraction as well, and that's sometimes really good. For example, if you're examining, you could get your crewmate to have a talk with the patient or try and distract them from what you're doing. But remember to try and keep that communication open with them. So although your patient is talking to your crewmate, don't forget to say to them, I'm just going to feel your knee, or I'm just going to have a listen to your back, I'm just going to tap on your chest. And that should reassure the patient that something's going on. So distraction can really help as well. Finally, one of the most important things is you've got to accept that you may not actually be able to do everything that you want. And quite often in clinical practice, if they've got a swollen and painful joint, you might be able to look at it, but they might not let you feel it and move it. And sometimes you've just got to accept that you're not going to be able to do everything. The same with if you're listening to someone's chest, they might be quite happy for you to have a look at it, but they might not be happy for you to percuss it or auscultate it. So sometimes you've got to revert to the history as well. But doing the steps above should give you the best chance possible to complete your physical examination with the patient.